Professor Mark Kilby heads up the fetal medical department at Birmingham's Women's Hospital. His interview will explore the way that a diagnosis of congenital heart disease is made, and will also explain the further tests that might be offered as the medical team look for a full understanding of the baby's condition. The mother's obstetric needs and care will also be discussed.
When an ultrasound difference is noted with a baby's heart, obviously there is a change in the way that obstetric care is delivered. The mother will continue to need to be seen by her local obstetrician and midwife when there be regular visits and the blood pressure and urinalysis and all the routine antenatal tests are performed. In addition, there may be a need to perform ultrasound scans locally just to note well-being and growth, good growth of the baby. There'll be a need for the pregnancy to be reviewed by a fetal medicine subspecialist and a fetal cardiologist, and that's usually done at regular intervals during the pregnancy. And with discussions between those healthcare professionals, there will be a decision regarding timing of delivery, mode of delivery, and also, of course, liaison with other healthcare professionals that will be looking after the baby once it's delivered. Once a baby has a special difference noted on the ultrasound scan with its heart, it's very important that the patient is seen by a fetal medicine subspecialist, usually in conjunction with a fetal cardiologist. This allows the baby to be examined in detail using ultrasound, really from head to toe, to make sure there are no other additional structural abnormalities which can exist with heart disease. In addition, some babies with heart disease can have additional problems like chromosome abnormalities. And chromosome abnormalities can't necessarily be seen with ultrasound, but you can sometimes get some hints from the ultrasound pictures that there may be a chromosomal difference, or maybe you can't. And there needs to be a discussion about checking the baby's chromosomes, whether that should be done before the baby's born or after the baby's born, because these additional findings can have an impact on the well-being of the baby at birth. Chromosome abnormalities are difference in the number of packets of genes that a baby has in every cell of its body. All of us have 46 packets of these genes, and sometimes you can get too much or too little chromosome material passing to the baby at the time of fertilization. These chromosome abnormalities can be very major abnormalities. In other words, you can have whole chromosomes added or whole chromosomes missing, or you can have very subtle differences which can be extremely difficult to see and need special techniques to diagnose. A discussion would take place usually at about 34 to 36 weeks of gestation to decide on the mode of delivery of the baby. This is dependent on lots of different factors, and I think it's my practice that this needs to be individualised for each person. It depends on how the mother is, whether she's well, whether she has any complications of pregnancy, for instance like preeclampsia. It depends on the baby, whether the baby's growing well, whether there's any compromise, if you like, of the way that the baby's heart is in terms of its function, and also involves on simple discussion of simple things like which way round the baby is, whether the baby's head down or bottom down. But as a general rule, there's no contraindication to a patient having vaginal delivery. It just needs to be managed individually. In general terms, there's no reason to deliver a baby prematurely. All that does is give the baby another problem to have to cope with, as well as the problem that it has with its heart. Once, though, the pregnancy reaches 38 weeks of gestation, there needs to be a discussion with the obstetrician, the midwife, and the parents themselves about timing of delivery. And often there is a discussion about delivering the baby between 38 and 41 weeks of gestation. Again, there is a requirement really to individualise care in every pregnancy, and certainly a discussion needs to take place on an individual basis. There's no right or wrong reason in terms of whether you allow pregnancy to continue to go into spontaneous labour or whether or not you consider induction of labour for logistic reasons so that there can be a neonatal intensive care cot available and so on. But certainly those decisions need to be made very carefully and with discussion with the parents and other healthcare professionals. The majority of ladies have a scan now in the United Kingdom between 10 and 14 weeks of gestation, but the majority of those scans are performed to check that the baby's alive and well, to measure the crown rump length of the baby to denote gestation, and also to check how many babies are present. The timing of a scan that looks for structural abnormalities of the baby is usually between 18 and 24 weeks of gestation, commonly at 20 weeks. Increasingly though, between 11 and 14 weeks of gestation, women are having ultrasound screening scans that measure nuchal translucency and denote a risk of the baby having a chromosome abnormality such as Down syndrome. And one of the spin-offs, if you like, of that screening program is that you can actually look at the baby in more detail and in particular look at the way the baby's heart's put together and the way blood flow is moving through the heart. Now, not all places in the United Kingdom offer that sort of first trimester screening. Increasing numbers are, but you need to talk to your own doctors individually to see whether that's available in the region that you live. The majority of pregnancies or ladies that have babies with congenital abnormalities, in other words differences in the way that babies put together, don't feel any different at all. That's why the majority of abnormalities are diagnosed on ultrasound and not for any other reason. Babies still move around, they often grow the same rate and are not associated with any other additional maternal problems than any other baby. Occasionally though, you can get decrease in fetal movements and some ladies have more excess fluid around the baby, but those are relatively unusual features to be associated with a baby. So the majority of babies that have differences in the way they're put together, especially heart problems, don't act in any way differently while they're in the womb than any other baby, so there's no reason why you would feel different. The vast majority of babies with heart disease have no other differences at all associated with them and they look completely normal at birth. Depending on the type of heart difference that is there and the circulation through the heart, the baby may either be pink or blue. That depends on the circulation of blood and the mixing of blood within the heart. Occasionally babies can have additional structural abnormalities. For instance, some babies can have a hernia into the umbilical cord called an omphalocele, which can be associated with heart disease. And so babies will have additional differences that you can see. But by far the greatest number of babies born with heart disease have no difference at all and look like completely normal babies. Usually there will be an obstetrician present at delivery, but if it's a spontaneous normal vaginal delivery, the obstetrician won't need to do very much at all. There will almost certainly be a midwife and also a neonatal paediatrician present at delivery, and a neonatal paediatric nurse will also be present. And they'll be there to assess the baby when it's born, usually on a resuscitator, and to make a decision about whether or not the baby needs to go straight to the neonatal unit or whether the baby can stay with mum for a time until further assessment is necessary. It's usual that whatever condition the baby's in, that mum, dad see the baby, can look at the baby before the paediatricians need to go on and assess the baby further and give baby more care. A resuscitator really is a high dependency bed really for a baby, and it has an overhead heater, it has an oxygen source, it allows the baby to be kept dry, warm and receive oxygen if necessary, and to be assessed in good light.